Okay, so we're live. Welcome to Magic Minds podcast. I'm absolutely excited and delighted to introduce today's guest, Maeve Nolan, Clinical Psychologist in the National Rehabilitation Hospital. Welcome, Maeve.
Thank you, Matt. Glad to be here.
Are you delighted and excited to be on the podcast?
Absolutely thrilled.
Are you
I'm nervous as hell.
Yeah, that makes two of us. How's Monday treating you?
Not too bad.
Yeah?
Yeah.
Monday's not too bad in work today?
No.
Brilliant. Look, I'm absolutely excited and delighted to get this interview. I've worked with you a couple of years. Not only have I admired you professionally, but personally you've given me a lot of time and encouragement in my role, and I can't wait to pick your brains.
Whatever's left of them, go on.
Yeah, it's been that day, has it?
My brain is beginning to fade at this stage of my life.
So look, tell me, how did you get into psychology? Clinical psychology.
Well, now that's a funny story, because when I did my Leaving Cert in 1974, all I ever wanted to do was be a teacher. Maeve was going to be a teacher from the time I was about 8. There's 8 of us in the family, and I'm the eldest girl, so I was always the bossy one, and I'm going to be a teacher. So after my Leaving Cert, go off to do the St. Pat's interviews and fail the singing test. I cannot sing. So having failed the singing test, I could not be a teacher, and I thought my life had ended. So a friend of my mother's called up and dragged me up to UCD. Those were the days when you could sign up in September, and said I had to go to college. So I took English and history and decided I'd be a secondary school teacher.
Right.
And I took psychology as a third, this minor subject that you don't pay too much attention to. And I absolutely fell in love with psychology, and developmental psychology in particular, child psychology and stages of life and what's going on for people. So at the end of first year, I dropped the English and history and stuck with the psychology. And that's where it started. And then clinical, I don't think there was too much choice in Ireland at the time. There were some organisational psychologists, but it was mostly clinical. And it wasn't as hard to get into training as it is now. So I went off to the UK for a few years and then came back and was one of the first to do the MPsych, which was called at the time. It's become a doctorate in the meantime. And that's where I started.
A little birdie tells me that you came in through, did you do psychiatry first?
No, I did psychotherapy after. I did psychology, right. And then I got a bit bored with, I don't know why I got bored, but I just did. I wanted to learn more, and I decided I would do psychoanalysis because I wanted to know what was going on below the surface. Okay. Psychology is often defined as the science of human behaviour, and I suppose I wanted to know what was happening in the mind.
Okay.
A bit like yourself, magic minds and mind matters and all of that.
Yeah, I'm intrigued.
I went back to do psychotherapy and worked as a psychoanalyst for a few years, and then kind of came back to psychology and married up all the various bits and pieces. And
so you have a ginormous toolbox of psychology weapons at your disposal, have you?
That's right, and I take them out and hopefully use them well from time to time.
We're not going to be a check for weapons of mass destruction around, are we?
Hopefully not.
Hopefully not. How long have you been here in the NRH?
Been in the NRH since 2001. So this is my 18th year.
Wow.
Now, I wasn't always full-time. I was part-time. I was working half-time in the Royal as well. And then, I can't even remember when I became full-time, but about 10 years ago. So here I am ever since. And I absolutely love it.
Yeah, I'm just about to ask you a question, what do you do? But before I ask you that, I read an article that you wrote, you were part of in The Independent in 2008, and I thought it was really descriptive, because people always say to me, what's it like to work out in the National Rehab? It must be depressing, it must be really difficult. One person actually said to me, do people be like banging their heads at walls and all? And I just found that unbelievably. But you described it well. You says it's not depressing, it's full of resilience and huge amounts of hope. Yeah. Do you still agree with that?
Absolutely, and I think that's actually, I'm glad you reminded me, Matt. People always say that when you say where you work. They say, oh God, that must be awful, or what's it like to be surrounded by all that much trauma? And in the beginning I would have felt like that myself. I don't think I could work there, but as soon as I started, and as soon as anybody works here for any length of time, even on placement or as an intern or as a volunteer, the sense of hope does strike you immediately, because you meet people who are maybe at the lowest point in their lives, but most of them are smiling, talking to each other. They're having their hard times as well, but they're actually figuring out, how do I get on with my life? And I think that's incredibly hopeful.
Yeah, I see it. Yeah, I see it daily, and you feel it. Yeah. Like it's not a difficult place to work. Yeah. Like, I mean, patience.
It can be. The work is hard. I think it's very hard. You're suddenly doing things for people that they never thought they were going to need help with. Young people, old people. You see 4-year-olds in wheelchairs. You see 17-year-olds who are GAA players in wheelchairs. You see, people who are just crumbling at 82 when they have a spinal injury suddenly. It is tough work, but it's good work in the sense that you see the hope and you see the resilience that shines through nearly all the time.
Yeah. Absolutely, absolutely. And that's really, really, really to the point. What is your everyday role? What is it that you do?
I guess one of the nice things about my job is that it's very variable. It's mostly to do with seeing patients one-to-one for either an assessment of their coping skills, their stress management strategies, a clinical interview just to see how they are, how has this affected them, do they want to see psychology when they're here, have they ever been depressed before. So one-to-one clinical assessment would be a big part of it. The second biggest part of it would be one-to-one psychotherapy with people who do think, oh yeah, I'm falling apart at the moment, or I'm finding this hard to deal with, or why did this happen to me, because I've already had other bad things happen to me. Why now? Why me? Why this?
Wow.
So that kind of one-to-one work, which is very rewarding. And then a lot of work with either staff or with the team to try and, I suppose, keep us all going and build up the sort of resources that we have as a team, whether it's educational stuff or just inputs for patient, working with yourselves, liaising with people around all kinds of committees and meetings and conferences.
Is your work predominantly with the spinal program?
Yeah. I only work with the spinal program. I think that's because I came here as a psychotherapist, and I remember when I was doing the interview thinking, I know all about depression and I know all about grief and I know all about psychotherapy. I'll be great in this job. I had no idea that that's not what this job is about, because most people aren't depressed. And I think that surprises people. Only about...
Yeah?
Yeah.
That shocks me. Say that to me.
Most people are not depressed. And there's some really interesting studies done across the world on resilience. Back to your point about resilience.
Right.
But basically, there's lovely studies done on whether it's the Twin Towers, ambulance men, firemen, tsunamis, Hurricane Katrina's, divorce, separation, first child, all the traumas you can think of.
Right.
The research across all of them is strikingly similar. And spinal cord injury is included in that group of traumatic events. Over 60% of people in all of those categories have what's called a resilient trajectory. In other words, they come to terms with it and get on with life. It might take some time. I'm not saying they do it instantly. They don't come in here going, I'm getting on with my life. But they, on the whole, get on with life in a resilient way. And that's the finding, which is striking. And only about a third would get depressed.
But people would think, it's just depression. We'll just label it, we'll call it depression. Yeah. But it's not.
It's not, no. And I think what's really interesting here is the patient will often say to you, I'm not depressed, but I'm really frustrated. I'm frustrated because I can't get a care package. I'm frustrated because I can't write my name. I'm frustrated because I can't go back home. I'm frustrated because my timetable isn't full enough. There's a lot of frustration, there's a lot of boredom, but that's not depression.
Okay.
And neither are tears. Sometimes when staff see patients crying, they go, oh, they're depressed. They're not. They're probably just, reacting to it. You or I would cry if we broke our necks or broke our backs.
Absolutely.
So for some people, it's a really healthy sign, but it can often be misinterpreted as, they're crying, they're depressed.
And then they're just given a label.
Yeah.
And then they're given meds.
Yeah.
And then they're in the wrong situation.
Absolutely. And sometimes all they're doing is working it through, which would be the psychotherapy term for it, working it through or processing it. And part of the process is to be up and down.
Wow. You just taught me something there. That's unbelievable. Yeah, it's
Can I tell you one more thing that I think is really important? It took me a while to learn it about resilience. Resilience is basically the capacity to bounce back. Okay? And I remember people in Spinal Injuries Ireland defining it for me one time, and that's exactly what one of them said, and it's also what's said in the literature. It's the capacity to bounce back, right? So people sometimes think that if you're resilient, you never have a bad day, and that is so not true. If you're resilient, it means you have bad days, but you know how to deal with them. Or if you have a bad day, you bounce back from it. So it's the bounce back ability factor rather than the never going into a bad day.
If somebody has the ability, if somebody has good emotional intelligence, that they can name it, I am sad, I am lonely, is that a help?
Absolutely, yeah.
Like if you can name it, if you can put a name on, you can put a vocal on, say, right, I'm sad today, or I'm...
Yeah.
That's the ability of being resilient.
Yeah, exactly. And also, it's the first step in dealing with things. If you can if you say, for example, I feel bad, well, you know, what kind of bad? I just feel bad. It doesn't allow you to do anything. But if you say, I feel frustrated because my family are not coming to visit me, then you can think, okay, I'll give them a call and see if they come up this weekend, or I'll see if I can do a roster, or I'll see if I can do something about that. But if you just say, I feel bad, or I feel lonely, it doesn't lead to problem solving.
Right.
Do you know?
Labelling doesn't lead to problem solving.
Not always, but it helps.
Yeah. So there's so many layers to it then, isn't there? Like, you know, unbelievable.
So many layers. Yeah.
Look, I dug up some research. You were part of a lit review in 2013 on masculinities lost.
You've been dragging up all my past sins.
I wanted to know what you're up to. You know, I like to do a little bit of research on me guests. I don't want it just to be about masculinity and loss, but we'll talk about for now. What was that all about?
Basically, that happened a little bit like getting into psychology. I got into that by accident. My real interest at the time, I'd been teaching gender for years. My real interest was women's issues. But when I decided to go back and do my doctorate, I was getting a bit bored, and I said, I'll go back and do my doctorate before I retire. And but there's more men have spinal cord injury than women, and it was going to be much easier to get a population of men. Okay. So I said, okay,
so we're the guinea pigs.
Women. You're the guinea pigs. I'll focus. To be honest, that was how I started. But actually, it was really good for me to do it. And also I learned an awful lot. And I still praise highly the 5 guys who were involved in the research, because I learned so much from them. You know.
Right. So what is it at the law? What was the masculinity lost piece was a review of the literature that I did after my doctorate, and that was to look at what effect does spinal cord injury have on masculinity. And of course, it's an impossible question to ask or to answer, because what is masculinity? It's a bit of it. I don't get it quite now. Yeah.
So it's like there's no such thing as the traditionally masculine man, and yet there's a kind of a culture whereby men are not supposed to, you know, show their emotions, react, talk, cry. These are fading a little bit, I hope. But they're still there. You're supposed to be the doer, the active one, the breadwinner. And I think when you're robbed of those things, it can be almost like a double blow, you know.
Absolutely.
You can be rendered very inactive when you consider yourself to be the active one. You can be passive when you've always thought of yourself as the breadwinner. It can be really, really tough.
Yeah, we've seen here with the brain injury program, you know, loss of identity. You know, all of a sudden the wife is now the bread earner. Yeah. You know, you're not, and it's so difficult. You know. Yeah.
Well, I always remember the guys that I interviewed for the thesis. They and I'll tell you a little bit about that, because I do think it's interesting and it's important. What I found was basically very common sense. Most people wouldn't know this, but I think very often psychology does that. It just puts a little bit of evidence behind common sense. But basically each of the men, every single one, and they were very different kind of characters, but they all mentioned little things that they couldn't do when they went home. I was specifically looking at how difficult are the first 6 months after you leave rehab, because the leaving rehab is meant to be a particularly hard time. Somebody described it as falling off a cliff. Somebody else said walking into darkness. It's a hard time because you've left the bubble of rehab. You've left the cocoon. You've left the physios, the timetable, the supports, the banter on the wards, and you're going home. And home may or may not be adapted, for example. But they all spoke of really simple things. For one man, he went home at Christmas and he couldn't put up the Christmas lights. And he said he cried more about the Christmas lights than he cried since he came in. So it wasn't the Christmas lights, it was just that was his job. Get the lights out of the attic, put them up. It broke him, he said.
Wow.
And then another man spoke about the coal. He used to be the one that got the coal. So it's the division of labour that happens, so that if you can't meet those roles anymore, it can be really, really stressful. You know, so the other guy mentioned he had a cervical injury, and he mentioned neighbours or family cutting his grass, and he had a big garden, so he saw them up on the lawnmower. He said it killed me. He said, not that they were doing it, I'd got over that, but he said what killed me was the way they did it. They didn't do it the way I would have done it, but I didn't feel I'd any right to give out to them because they were doing it for me. So you get caught up in this double bind of I'm really grateful to them for doing it, but they're not doing it right. And that's so hard. You can feel the pain. You can't say anything because you're supposed to be grateful.
Right.
And that's another problem often for people, the burden of being grateful, the burden of gratitude. Thank you, can I have that? Can you get me that? Can you do this? That's a very big burden. And it doesn't fit with masculinity. I don't think it fits with femininity either.
It doesn't fit. We don't want to, you know, and it gets cringy then. You think you're being over nice, and you see trainees here, you know, it's a seriously difficult one.
Yeah. And I suppose the whole thrust of human development, and that developmental psychology is my thing that I'm so interested in. Like kids from the time what age would your little one be before she'd say, do it myself? You know, it's about doing it yourself, being independent. And suddenly your independence is taken away, even if it's only temporary. And that is so tough. That is so tough.
Absolutely. Jeez, that's a fascinating...
But I think the big challenge for people, and this is hard for particularly for people with very high level injuries, the big challenge is to get back what's called, I don't like jargon, but this is a good phrase, I think, decisional autonomy, so that you're independent in making decisions.
Okay, that's a good one.
Isn't it?
Yeah, absolutely.
And I know a quadriplegic, he is a Swiss psychotherapist, and he said to me years ago, you've got to learn to become independently dependent. And I thought, when I heard it first, I thought, that's a bit, sounds nice, but it's not a great. But actually, I've never forgotten that phrase. You've got to be independently dependent. It's a great phrase.
It is a great phrase.
Because it's quite a paradox. How can you be independently dependent? Or it's a bit like saying you have to plan to be spontaneous. They don't fit,
it's
but
a
you
bit
have to do
counterintuitive,
it.
isn't it?
Yeah.
But what says to me about that is it's giving power back to the patient. Yeah. And we do it here. And I struggled with that when I first came into a job, was I wanted to help them. I wanted to do as much as I can. Yeah. And you know what? They have to do it themselves. Yeah. They have to want it. And they get more benefit from it when you do, and they empower themselves and when they own it.
Yeah. But sometimes it's easier to step in and do it. It makes you feel good because we like to do things for people, and also it's quicker. But if you have to stand there and watch them and you go, I wish they'd hurry up.
I've had to let trainees miss appointments over in the OPD or miss because it was beneficial to them because they didn't recognise you had a memory problem.
Yeah, there you go.
And you want to just help and fix it,
But then you have the other side of that, I suppose, is the time poverty bit. I remember a woman saying to me, why would I struggle for 20 minutes to put on my bra when a nurse can do it in 2 seconds? So there's a bit of choosing, and maybe that's back to the decisional autonomy. There's choosing what to do. I don't want to spend 20 minutes putting on my underwear because I want to go to a kitchen group, or I want to go to a book club down the town. So you have to choose. So sometimes asking people to do things is good, and sometimes asking people to do things is not taking on the responsibility. And how do we know which it is?
It's getting the balance, isn't it?
Yeah.
But sometimes patients can be brilliant at that, can't they? You know, choosing when they want to be independent,
Absolutely.
when they're not. You know, they can really, I've met some people that have had horrific memory problems, but then when you ask them to come in and do something, or do you want to do something for themselves, they remember, produce says so.
Selective memory problems.
It's brilliant. They're very resourceful. Look, let's take it outside our role. How would you describe mental health? Like, it's a big one. It's in the news. Everyone's talking about it. I'm not a fan of the word mental health because of mental. Because I mentioned mental, because probably when I grew up, everyone was slagged, he's mental or he's mental, and it just doesn't fit now. It doesn't for me. How would you describe it?
Gosh, I suppose I would think more about the concept of well-being, maybe. And I suppose because I trained as a psychoanalyst years ago, I do think of Freud's basic terminology, which is the capacity to love and to work. So I often think if you can love or work, or preferably both in your life, you're doing okay, because that's an anchor then. And that's why, just back to work for a minute, when you have a spinal cord injury, it's often just so important to be able to get back to work, because that's a core part of your identity, which feeds your mental health. So mental health, I think, is the capacity to love and to work. It's not a bad definition. Yeah.
So, there's so many labels out there. We just touched on depression, anxiety, all these bipolar. Like, do they all just fall under the one umbrella?
Labels are tricky because there's a very good, sometimes people think, I was so pleased when I got the diagnosis. It might even be something extreme like a cancer diagnosis. Why were you pleased? Because at last I had a label for what was wrong with me. So sometimes it's reassuring, sometimes it's nice, and sometimes it's really limiting. Like calling a patient challenging means that they're challenging and nothing else. Or, calling somebody disabled means they're not also able to do lots of things. there's just so many contradictions to labels, I think. So I treat them a little bit warily. And yet, when something goes wrong, you do kind of want to know why. And you want to know why, what's wrong. You know, is it manic depression? Is it depression? Is it psychosis? They are helpful, but they're overused, you know.
Absolutely, absolutely. What's your take on the current mental health crisis in Ireland at the moment?
What do you mean specifically? Like
it seems to be huge at the moment. And like you look at Twitter feeds, it's like, you know, it's everyone's talking about it. It's out there. It's
again, and I know psychologists often do this. They kind of do the good and the bad, but the good bit is people are talking about it. And you might have, for example, the guy that you spoke to last week talking about his memory problems. It might really help somebody else. You've got Brezzy talking about his anxiety. You've got people talking about feeling suicidal. That gives other people who feel bad hope. So I think it's good to air it. And then the other side of it is the mental health services are stretched to the limit. Maybe a bit the same as rehabilitation services. They're stretched to the limit. And when a family member of my own was suicidal, and he was a young man, which you would imagine would press all the buttons and he'd be immediately minded and sent to services, there was no services there for him.
No?
Nope. There are charities, there are the external services, like Pieta House, who are doing really, really good work, but there was no actual HSE services. His family had to fight really hard to get him into a psychiatric hospital, and even then it was 5 weeks before he got any psychological input. That's sad. That's sad that for a young man at that vulnerable, known as a vulnerable time, one of the highest rates of suicide, it might even still be the highest, is young men, that there isn't help there, you know.
That's alarming, isn't it?
It is alarming. There's very few services for that late adolescent age or young adult age. So, yeah, the mental health crisis is a problem. And, of course, homelessness and asylum seekers and all kinds of other issues are going on that are interlinked.
You just said something in your conversation there that people are talking about it. They are talking about it. Do people want to hear it? If I came to, not to you, but do staff members, do other people, look, whatever, Johnny or Larry or Mary, I'm feeling really down today. Do they want to hear it? Are people open to it still, or do people get uncomfortable about it?
Probably a little bit of both, and I suppose you have to choose. One of the things we'd say to people, as you know yourself, Matt, because you're on it, the suicide awareness group here in the hospital.
Absolutely.
You have to. It's good to talk about it, but it's also good to be selective about who you talk to. Talk to somebody who might be able to hear it. And I suppose the good thing about celebrities talking about it is that some people will listen because they're celebrities. Which is nice. Or a GAA player comes to the school and said, you know what, I might have won that All-Ireland medal at the same time I was battling with depression. It does make people sit up and listen. So talking about it is definitely a good thing. But sometimes one-to-one with people, they will say to you, I can't keep going on about it. I can't keep telling my family I feel miserable. They don't want to know anymore. So people do shut off.
It wears thin. And you feel like you become a burden,
Yeah.
But back to that point about saying it to somebody, I remember once I have my own struggles with anxiety and feeling worries and all that. I remember saying to us that, like, someone said, how are you today? And I just went, I'm not great. And I could see a change in their face. Their face dropped. They didn't know what to say. They probably didn't expect me to say it because I like having the crack most of the time. But when I honestly said, I'm not feeling great, they went, boom. They didn't know what to do with it.
Yeah.
And a part of me was like, oh, I feel sorry for you now that I've said this to you.
Yeah.
And there's this two-way thing.
Yeah, that's interesting, yeah. And particularly when somebody who's usually very jovial or bouncy or good-humoured, when they say something, you go, oh, God, he must be really bad if he says something like that.
Yeah, and I actually wasn't. I was just feeling a little bit sad that day. And I was like, I might as well just tell you now that you've asked. Yeah. But is it a very Irish thing, is it? How are you getting on, but I don't really want you to tell me.
Well, it's funny. I don't think it's Irish. I think it's human. One of the things that I remember learning and that is helpful to me when I was training to be a psychoanalyst is the difference between empty speech and full speech. And empty speech is just words. So how are you? I'm grand. That doesn't mean anything, or barstool talk, or just, I'm grand. Sure, isn't life hard? And you just have to get on with it. And all these words, they're just cliches strung together. They don't mean anything. That's empty speech.
Frivolous.
Yeah. But if you say real speech, and you say, I'm feeling really bad, you can see people's faces, you say, changing. So you have to choose when you say it and how you say it.
There's a lady called Brene Brown, and she talks about vulnerability and who you open up to, and if they're willing to walk into the arena, or if they've been in the arena. I just thought it was really good. Do you think men are good at being vulnerable?
No.
How do we change that? Is that through the Brezzies? Is that through the talking about it? Is that through led by example?
It is that, and yet I think you can see the contradictory things happening in society with the Me Too campaign, with the Belfast rape trial. You can see this if you like, the highlighting of very traditional masculinity at the same time as society is supposed to be changing, and we've got softer, we've got permission for men to be softer, we've got more acceptance of gay relationships, gay marriages. We've got all of these things happening which should be good. Men are taking more part in child rearing. And yet we've got the sexual piece still going on. Okay. I don't know what that disjuncture is about, and I think it's troubling.
All that stuff you said there, all the rights and all the awareness. It's there's lots of divides happening again. Them versus us, that side, the left, the rights, the males, the females, the masculinity. Sometimes I'd be afraid what to say. Do you know what I mean? Like I was on a weekend and there was talk of that Belfast trial, and I just said I can't talk about that because I didn't know whose feelings I'm going to hurt.
I know.
I was really worried. I didn't want to say. I didn't even want to give my opinion because I was like, I'm just going to say nothing.
Yeah. And I think that's it. There's a kind of a frozen piece to us all now. We just don't know how to react anymore. And that makes it hard too, because the conversation then can get stuck, or it can become like a witch hunt, or it can become like a battering either men or women or whatever. And that's hard. It polarizes people. So I'm not sure how there can be a reasoned debate. Sometimes it's time. We need time, I think, to let those things sink in and see what they mean. But it's a very tricky one, It really is, because I remember thinking, I won't even mention names, but one of the guys coming out of that trial and feeling, he doesn't really, that wasn't in any way an apology or contrite, and then a week later there's a big long apology, and you think, now, is that genuine, or has it happened because there's been a week of media? Should we have known who they were in the first place? Should the victim have been recorded? There's so many questions about it. We won't even go there tonight. It's too big a question, and it's still too raw. I find it still hard to even process it.
Yeah, me too. It was a landmine. I was like, I'm not going over to that garden. I'm not going near that.
But if you were a young woman who'd been raped and were thinking about taking a case, I don't think you'd be going anywhere with your case after.
I was listening to Blind Boy. I listen to Blind Boy's podcast a lot, and he was saying that he read out some statistics of 1 in 9 actually only report, 1 in 10 only report, and then only really small to ever go forward towards the courts, and then not a lot of them. It doesn't really give young girls or women encouragement to go forward to that, and it's sad, isn't it? And it's scary.
It is sad.
I was actually talking to a guy just by coincidence. Worked in Wheatfield Prison the weekend. We bumped into him when we did gymnastics, and he was talking to me about those cases. And I don't know much about law, but he's basically saying that, I might be wrong, he might be wrong, but this is what he told me, and it fascinated me, that those guys that were charged went with solicitors, barristers, but that girl only had the prosecutor with her. She's basically on her own, and he's actually not even on her side. He's working for the state. So she's basically turning up there on her own, being grilled by the other side. Like that's not fair. That can't be fair, whether she's right or wrong.
No. And show us what you were wearing that night. Show us your underwear. They didn't ask the guys to show their underwear. Like,
on her own. Like
there's so many things.
Whether she's telling the truth or whether they're telling the truth, whatever.
Yeah.
She should have a gang of people with her. Like that's not a fair fight.
Yeah. So many things were wrong about it. Yeah. Nolene Blackwell is very good on it. The woman from the Rape Crisis Centre. I think she's a sound woman, and she was it was unfair in many ways. But before even jumping to any kind of judgment about who was right and who was wrong, just the process is wrong.
Absolutely. And apparently they €500,000 bill for solicitors for that, so they've obviously thrown everything at it.
So right. The only people laughing then are the solicitors.
Yeah, let's get away from that. What's your take on the term man up? Why I say this to you is I've heard it lots of times by people saying, but one poignant one was a trainee rang me that had a brain injury, and he went to a solicitor, and they sent him off, but the other side sent him to see this psychologist, and he basically said to him, you can do all the psychology you want, you've had to have a brain injury, but sometimes you just have to get on and you kind of have to man up.
Yeah.
And my head nearly spun off when he said that to me. He reported back and he said this to me, do I need to do that? He said to me, what's your thoughts on that?
Oh, you have all the hard ones, Matt. That's a very hard thing to be told when you're already struggling with the implications of brain injury, because it seems like it's entirely in your gift to man up and do something about it. That's clearly not appropriate. However, sometimes in therapy there would be a need to challenge somebody, hopefully not with a phrase as glib as that. But sometimes you do have to challenge somebody, and you wouldn't ever use a term like man up. So it might have been meant as a challenge, I'm not sure, but it didn't. It doesn't sound like it came across well. It's not helpful, I don't think, because it's again saying to somebody, you've just got to get back out there and be the traditional man, and that brings the traditional male stuff back into it. Be strong, be active, don't be upset, don't be vulnerable. So it's a very mixed message to be giving people.
Yeah, it's basically, like I mean that to women as well. Man up, like, get on with it. This whole thing of get on with it. You need to just get on. That does need, as you said earlier, the resilience. There has to be that part of it.
Yeah. I think the funny thing is, and I notice it here an awful lot, if a patient says to another patient, you just have to get on with it, sometimes that can be so much more than a cliche. It can really help. Whereas if a psychologist says to a patient, you just have to get on with it, it's like,
is that a judgment?
She is? Yeah. But sometimes if a friend says it, or a peer who's going through similar dilemma, you kind of go, yeah, he just got on with it, I can do it too. It can be motivating. It's
like a mirror. Yeah. If he can do it, I can do it.
Yeah.
But if I say, if a professional says it and they're wearing the white coat, they know best, teacher knows best, so he's put me down. Yeah. It's a put down. So
that's why timing is important, readiness is important. I definitely hope that therapist didn't say it on session 1, you just have to man up.
He was working from the other side. He was on there, so it was a claim. Okay. And he had to go and see this, and you just have to kind of get on with it, you just have to man up kind of thing. Mm-hmm. And it was a significant brain injury, and this guy worked really hard at his rehabilitation, and he was a great guy. He had a huge anatomical change to his brain. Yeah. Like it's just not possible. And he's got, as you know, there's a lot of social stuff going on. There's tons. Yeah. Just to make that one statement.
I think one of the lovely things, and I'm very lucky, I think, to be a psychologist. I think one of the lovely things about my work over whatever area I've been working in over the years, I've got time to talk to people. And when you talk to people, you always realise there's so much more going on below the surface. Freud very famously used the iceberg analogy, where you've got 1/7 appearing above the water and then 6/7 below the water. Or a swan paddling, they look so serene and then they're paddling like mad underneath. So what goes on below the surface is huge. And I sometimes have time to talk about that if patients are willing to do that, or if people are willing to do that. But sometimes if you're, say, on a busy ward, you don't have time to be thinking about what's going on below the surface. And we're inclined to jump to judgment and say, why can't they just behave themselves? Or why can't they just be good patients? Or why can't they just get on with their therapies? Or why can't they just get into a wheelchair? There's kind of these quick, why won't they do things? Whereas I think when you have time to talk to people and you find out why they won't do things, that makes so much sense. So it's about making sense of things and helping them, hopefully, to make sense as well. But we don't always have time to do that. A teacher has a classroom of 30 kids, a nurse has a ward of 19 people. Like, how do you give people the time that they deserve? It's a hard one.
It's a difficult one, isn't it?
It's a difficult one. So it's a privilege to be in a role where I am able to spend time talking to people.
Brilliant. On the mental health, depression, anxiety, what's your thoughts on antidepressants?
That's a little bit like asking what's your thoughts on crutches. Sometimes you need a crutch.
Okay.
But hopefully you also... Now, this is not a very good... I'm just after walking myself into a hole because I work in spinal injury. But if you break your leg and you need a crutch, you obviously need your crutch for the first 6 weeks and then you throw it away. Sometimes antidepressants are like that. They might be that crucial crutch that you need. But once again, they're overused, completely overused. People are very good at putting patients on antidepressants. Who reviews them? Who takes them off them? Who gives them alternative strategies as well? So antidepressants can help, but they have to be combined with other things so that self-management can take over.
So you're going to have, and I said this on another talk I was doing, when you need to have all your ducks in a row. They don't fix. They're not and people
they're
look
not
for them.
an easy fix, and they don't work very quickly either. And people don't realise that. I'm feeling really bad, and they're prescribed antidepressants, and the next day I don't feel any better, or I feel much better, but actually they haven't kicked in.
The placebo effect. I was at a talk here, and one of the consultants was doing it was on pharmacology, but he'd done a lot of supplements after brain injury. And I think before we even got to the end of the conversation, he'd done all this, and then it was the antidepressant. I thought that was good.
Yeah.
I thought it was a great look.
Yeah.
You know, that we're looking at the nutrition, we're looking at the sleep, we're looking at the behaviours, we're looking at the everything before we go down the road of antidepressants.
Yeah. Yeah. Well, back again to this, you know, the young relative I mentioned earlier, like, you know, he was eventually put on all kinds of a cocktail of antidepressants, but he wasn't doing anything to get himself outside of his cave. He lived in a cave in his house, you know, where nothing was asked of him. Everybody was minding him, and, you know, poor guy, he needs help, and, you know, but so he wasn't participating in anything. So he wasn't learning any social skills. He was just doped up with antidepressants. So if he was on antidepressants and also continuing to do stuff, there was a chance that participating in life would have also kicked in.
Wow.
So, you know, it's about how they're used and, as I say, how they're reviewed as well. And they're expensive. There's there's a vested interest in the pharmacy industry to
the big
keep us on
pharma.
them.
I've a whole opinion of that. We won't get into that. I myself, I think when we deal with trainees here, the lifestyle is not looked at. All the other stuff that they do is not factored in. You know, the physical exercise, the nutrition, the sleep, and the environment. Like, I mean, when I say environment, I mean the relationships in the families.
And do you know why they're not? Why would you think they're not looked at?
Because they can't fix them.
Partly it takes too long. It just takes too long. If you go into a GP surgery, there's a famous book years ago now, 6 minutes for the patient. I don't think they even get 6 minutes anymore. But you've got a short time. And the easy fix is, oh, we'll try this. We'll put you on antidepressants. Instead of, what have you been eating lately? Or have you been sleeping? Do you go out? You know, it's a much bigger question.
It's a bit woolly. That's a bit like, oh, what are you eating? Why? And they were like, just give me the pills, doctor. And the doctor was like, I'll just take them and go off with your thing. Yeah. But it's unreal, isn't it? Yeah. So what do you recommend for people that, you know, that are suffering, like, you know, bouts of sadness, depression, mood thing? What would you advise people to do?
I suppose because of my work here, if they're an inpatient, it means that they're fairly recently injured. So one of the key things is time, you know, and that's
don't
hard
have time.
to say. I know they don't have time because
they
they
don't
feel
have time.
better now. Yeah. But it's a bit like grief and bereavement. Sorry, I'll come back to your question. But grief and bereavement, most people who are grieving in a normal way do not need psychotherapy or psychology. They need time. It takes 18 months to 2 years to cope with most major life events. So if you have a spinal injury, it's going to take time. But if somebody comes into my office and they're in distress, you don't say to them, well, it's going to take time, you know, you're going to feel okay in 18 months, bye. You can't do it like that. But it is one of the key things that they do need is time to process what's happened, time to look at their, what you called earlier, identity, anyway, so that's time. So that's one thing. The other thing, there are kind of shorter term strategies to look at what has happened and how you might deal with it. And one of the key pieces of research is to look at how has what has happened interfered with their value system. And very often when you ask people what's really important to them, they might say kids, family, their work. And you say, well, how has that changed with your injury? Oh, no, that hasn't changed, but I can't walk. Or that hasn't changed, but I've got terrible pain. So it's to say to people, look, life does go on and you're still the same person and your values are still important. And the main outcome of my own research was continuity as well as change, which sounds blindingly obvious. But really, it's just that people think in the beginning that everything has changed. They'll never be the same again. And that kind of disruption disturbs us. It makes us vulnerable. Yeah. There's a new way to get into a car. There's a new way to have sex. There's a new way. There's a thing called bed mobility. There's all these things you never heard of before. There's bladder, bowel care. So everything seems to be about change when you're in acute hospital or newly injured. But actually, when you go home, even within 6 months, as these men talked about, there's much more continuity. I'm still the same person. Okay, I can't put the lights on the Christmas tree, but I'm still their dad.
Wow. I
can still talk to my wife. I still have my sense of humour. I still like the neighbours down the road, and that neighbour still drives me mad. I'm still the same person, but I have a spinal injury. So that's again time, but it's also just looking at what stays the same. I often say to people when they come into hospital, it's like, or when they have an injury first, all they can see are the doors that close. Can't play football anymore, can't run with my kids, can't climb up those stairs, I'll never get upstairs in my house again. There can be an awful lot of can'ts, an awful lot of doors that seem to close. What they never see, because you can't, are the doors that open. For example, Paddy Monaghan didn't decide when he was a child that he wanted to win the Dublin Wheelchair Marathon, but he's won it 3 or 4 or 5 times because he had a spinal injury.
Right.
He's now a wheelchair marathon person.
Gotcha.
Do you know, that wasn't his wish or his dream. But because he had an injury, he thought, what can I do with all my sporty energy? So he channeled it into something else. Mark Rowan, who won in the Paralympics, he didn't decide to be a hand cyclist. So doors do open. People who have injuries didn't think they were going to be an advocate for disability. They didn't think they were going to go into schools and talk about workplace safety. Doors open. New opportunities open.
Absolutely. And I've met trainees in this programme that have had a brain injury. And I wouldn't say it's been for the benefit of them, but they went on and done things that they'd never have done before. Went on and done, they finished education. They've got out of crime. You know, they were going down a road that, you know, got into drugs and it brought them somewhere else.
Absolutely.
But if you said to somebody, this fella had a significant brain, you go, oh, his life must be really bad. But they would tell you, it has opened doors for them and they've done well.
But it's a matter of timing, and this is the delicate piece of the work that we all do here in NRH. You can't say to people in the first week, well, you know, all these doors will open and you'll be fine, you'll be able to do all these things and you can go back to college. And that's the best way to alienate people. They can't hear that because they're not ready.
No,
But if you know in your heart that can happen for them, you convey hope. And there's a very good study done on what do patients want from rehabilitation. And it doesn't talk about fancy environments and single rooms and all these lovely things. It talks about hope for the future. They want staff with a positive attitude. They want staff with hope for the future. And that's not to do with, you know, the built environment. It's just to do with attitude. So I think that's the most important thing.
But you have to believe it.
Yep.
You know, as a therapist and I work with people, I genuinely believe it. You know, because I can see most of them when I meet a trainee, or I can see the end product. I don't know how we're going to get there, and again, I can't bring him along. I can't push him along. I have to just encourage him and show him that there's hope at the end. And I think it's a huge responsibility of us. Well,
also, I think you're a little bit like a fisherman. I've never used that phrase before, but I'm just thinking of it now as you described it. In the first session or two, you're kind of fishing to see what's this person's strengths. Are they going to be able to do it? Yeah. And my key thing, long before I started work here as a psychotherapist, my key thing, if somebody can laugh at themselves or at the world or in any way, even if it's dark, black humour, if somebody can show any humour in session 1, they're going to be okay. Now, that's way too simple, but I've actually I've never changed my mind on it. People who can show some sense of humour really can mobilise other resources, because I think it takes perspective. I think it takes the ability to look at things a bit differently.
Yeah.
And if people are terribly serious, I can't live like this. This shouldn't have happened to me. This is not possible. I cannot do this. If that seriousness goes on, then I think things can be pretty bleak.
But would that not eventually pan out? You know, you can't stay that depressed or down or middle for long. Will the brain not just work out of that? Or are you in serious hot water if it stays permanent? Is that like...
I think what we said earlier about resilience comes into... Most people do find a way of, you know, either laughing or having a bit of banter or talking about things in a... I don't mean... I'm making that sound easier than it is. I don't mean that it's easy or light or ha-ha-ha kind of humour. I just think if they've some ability, and Irish people are good at it, of saying, sure, look, you know, I'm always a lazy sod and now here I am sitting down for the rest of my life. Anything. That's not a good example, but something just like that would give you a ray of hope. But if it's terribly serious and why me, maybe they're the small number of people who do slide into a depression, you know, or maybe time does kick in and after a couple of years they find something else or an opportunity arises, but it's harder for them. I think people without some kind of a sense of humour struggle more.
Yeah, absolutely. I found that it's you have to find that bit of hope for them.
And when you're passing in the ward sometimes up there and you hear the crack going on after a session, or there's a good bunch of lads in or a good bunch of women in the ward and they're having a bit of fun, there's nothing like it. It's quite uplifting.
It's refreshing.
It is.
I have to say, when I started working here as a full-time, I came to this part as a student, but when I was up in the physio department in 2000, my favourite people to do were the polars.
Yeah.
The amputees. I've never met a crazier bunch of funny people.
Yeah.
Like, you know, one leg, half a leg, two legs gone, the crack, and the antics that they used to get up to, the drinking. Let's not rat them out, but they were
a lot
bold.
of people would say that when you become disabled or when you have a spinal injury, you're allowed to have crip humour, which able-bodied people, you have to be very careful what you say, but they can slag each other in a way that you kind of go, oh, dear God, did he really say that? You know, they can be very funny.
Yeah,
very funny.
Yeah, absolutely. This is a difficult job. We're in dealing with trauma. Does I think, if you'll be familiar with vicarious trauma, what's your thoughts on that for staff?
I think it's a real thing. I think it's a very real danger, and it's probably one of the key ingredients of burnout. While we're not traumatized ourselves, we're surrounded by trauma. We're surrounded by people who are at a dark place in their lives, maybe the hardest period they've ever gone through. We're surrounded by... Just sidetrack for a second. I read this sentence once which stopped me in my tracks, and it said rehabilitation can only fail. And I thought, what? That's an awful thing to say. But what it meant was...
Say that to me again. Sorry, go again.
Rehabilitation can only fail. I thought, what?
Huh?
Yeah, exactly. What? But actually what it meant was, and it's not true, rehabilitation doesn't restore people to who they were. Most people do not leave here as good as they were before they got sick.
No.
And in that sense, it can only fail. So people are always going to end up leaving here with some form of, for some people, thankfully it's lesser than for others, but for some form of impairment, whether it's mobility, bladder bowel issues, pain, brain injury, whatever it is, you're going to leave with some kind of impairment and have to learn to deal with that. So that is tough. And I think as staff members, we're working in that environment the whole time where people have a sense of disappointment about, they're delighted very often, thankfully, with rehab, and the feedback that they give about staff here is excellent, but they often leave quite disappointed because they're not who they were. They're going home to challenges and struggles, and I think that takes its toll. Families coming in and, you know, seeing wives and husbands with, you know, partners who've changed personality, or maybe are in a persistent vegetative state, or maybe, you know, can't speak after a stroke. That's massive. And to be surrounded by that, we begin not to see it because we work here and we see it. It's only when you hear a Ryan Tuberty or a reporter come in and they say, I was in the National Rehab last week and oh my God, the work they do is amazing. And you see all these people and you can see them looking at the queue for the canteen or something, and they're pretty thrown away and blown away by the enormity of what they see here. But we just potter along because it's part of our everyday life. But I think it does take its toll, and I think that's why we all have a responsibility. And the PWEG group here, the work that Rose Curtis does, the work of, you know, occupational health, it's just really, really fabulous, because we do need to know what it is. It's American, called it soothers. What are the soothers in our own life? What are the things we use to make us feel better? You're very good at it, doing the boot camp, doing your running. I started and gave up, but I should go back to it. Sheila's Pilates, yoga classes. Find something.
That's my question. What do you do? Yeah. How do you soothe your vicarious trauma?
I'm a little bit of a dabbler. So in December, I did the December challenge and I felt great. And then I immediately dropped it and haven't done it since. You know, I'll do a little bit of boot camp and then I say, oh, it's too early in the morning for me. So I need to be more persistent. Left to myself, I'm a reader, and cinema is one of my big things.
That is one of my questions, but I'm not going to get to that about the reading. So it's about being active. It's about being mindful. It's about being aware of it, isn't it?
Yeah.
See, I have to be very careful here. I love having the crack, but I like it. I want everyone to do it. I want everyone to be involved in it. Yeah. But sometimes I just always having the crack. But I just want that to be the atmosphere. Yeah. That it's not all about the trauma. And I think patients and the trainees here, they appreciate that. Yeah. That it's not all doom and gloom. And if he's happy, then I'm going to be happy as well.
Yeah. It's a really fine line that I'm sure you do feel like a tightrope walker sometimes. That works maybe most of the time, but certainly with spinal injury, and people would notice this when they come from working with brain injury to working with spinal injury. Some of the people with spinal injury, they're obviously not brain injured. They're completely what we call cognitively intact, which is an awful phrase. But it just means their head is, there's nothing wrong with their head, even if they can hardly move a muscle.
Okay.
But they're thinking. And if somebody is flippant or too humorous, if you like, I'm contradicting myself now, but it can be too much.
Of course. You have to get the old social intelligence
absolutely
finely tuned.
Yeah.
And you learn that with trainees with brain injury. Yeah. You know, what you can say to one person, you can't say to the other.
Exactly.
You have to choose your words.
And positive psychology, all this stuff about mindfulness and positive psychology, it's all very good and it is all very positive. But I read a brilliant article by a man who had a hang gliding or a paragliding accident in Australia, and the article was called "Let Me Grieve My Broken Body." He said all this stuff about positive psychology is fine, but if you can't or don't feel positive, then you feel like you're failing. So you're doubly disadvantaged. You've had your injury and now you're not even able to be positive about it. But you can't be positive about it all the time. And maybe there's that early grieving phase where you want to grieve your broken body and then you get on with it.
Yeah.
So it's about being sensitive the whole time, and what will apply to one person in one bed won't apply to another. And if you're the kind of person who wants to apply the same processes to everybody, you shouldn't be working here. You have to be flexible. And that's hard because our processes, our protocols, our guidelines are all about, if this happens, this is what you do. And that might be true 80% of the time, but there's just sometimes it's not the best way to be.
I'm sorry, I don't work like that sometimes. I'm a bit of a rule breaker.
I thought you were a tick boxer, man.
No
you
way.
look like a tick boxer.
No way.
I'm joking. I'd say you're the least tick boxy person I know.
You're dead right there. You have to, and that's what we've got a great autonomy in this program in the RTU, that we can adapt the program to the needs of the person.
Yeah.
We've got a great manager, and she encourages us to do that as well.
I think one of the great big paradoxes of health at the moment, and I don't have an answer for it, I wish I did, is that at the same time as there's so much talk about patient-centred care, I think it's funny that there's a parallel process going on that we should complete more forms and tick more boxes. Ticking boxes is not patient-centred because patients are not box size. They're just different and unique and they need to be treated differently. And I think that's one of the hardest things for this protocol-driven, guideline-driven, regulated environment to take into account.
Well said. So what books are you reading at the moment? I'm really fascinated with reading books. So what are you reading at the moment? I'm
one of these people who reads about 5 books.
I thought that was just me. I've 3 on the go at the moment.
Paul Carroll gave me one recently. The Situation is Hopeless but Not Serious, which I think is a great title.
Who's that boy?
Can't remember, some long complicated name, but it's written by an American researcher and it's basically a tongue-in-cheek guide to how to be truly unhappy.
Wow.
I love it.
Excellent. Is it a small book?
Tiny little book. I'll ask him, can I give it to you? What else am I reading? I love books that are kind of real, not autobiographies, but real life accounts of something. For example, a brilliant one I've read recently because I was in India in February is called Shantaram. I'd never heard of it before, but somebody told me about it, and it's about an Australian guy's experience of being in Mumbai. Brilliant, absolutely brilliant, because it's kind of true. And then because I was in South Africa recently, I've had a good year of travelling, a book called My Traitor's Heart, which is about a journalist in South Africa, looking at his family's role in apartheid. And it's just brilliant because it's real, you know.
Yeah, I like that.
And it's not really the story of him, it's the story of Africa at a certain time.
Wow.
I love stuff like that.
Yeah.
And I love novels as well. So
that's what you're reading at the moment. So you have 3 or 4 books on the go.
3 or 4 books on the go. For different moods.
Do you meditate? What's your thoughts on meditation? Why I asked you that, and it's funny you talked about earlier when someone says, I can't even do the positive stuff right, and again people then go, oh, I must be really broke. And when people get into meditation when they're in a crisis, and I can't say depression or anxiety, but when they're not feeling great and they try it and they find it difficult is another stick to beat yourself with.
Yeah.
You're like, oh, no, I can't even meditate. It's very difficult to meditate.
It's very difficult to meditate. And I think I can't do it, which is why I'm very ambivalent about mindfulness. It's not that I don't think mindfulness is good. I think mindfulness is good for other people. And it's not good for me. And I think probably because I need it badly.
Yeah.
I'm too impatient. It's too slow and thoughtful. And it's a bit like slow cooking. I think it's really important. But when I go home at night, I want something in 5 minutes. It's like maybe when I retire, I'll do mindful thinking. But increasingly, I do consciously look at, I'm just looking at the sun shining on that pipe out there. Like there are lovely things you see in the world, and I'm paying more attention to little things like that. I'm paying more attention. There's a leaf on that tree that wasn't there yesterday. That to me is mindfulness. I don't need to sit in a quiet room, bring my cushion downstairs, sit cross-legged, because it makes me uncomfortable anyway.
Yeah.
So I don't know. I think it's an old idea that's dressed up in a new box, and we're all supposed to go, oh, mindfulness.
Yeah,
Yeah.
I'm practicing at the moment, but it doesn't give me the same effect as doing 10 press-ups or a few pull-ups. I want to have swollen biceps, or I want to have a swollen chest. I want to feel like bang for buck, I'm getting something out of this. But at the moment, I feel like
you macho man, you man.
Yeah, me fragile masculinity. I'm like Willy Wonka. I'm just buying the ticket because I hope to win a prize, because I'm doing the mindfulness because everyone says, oh, it's good for you and it's great, and I'm giving it a go.
Yeah, I feel a bit the same. I feel I should be more positive about it, but I know in the psychology department, don't talk to Maeve about mindfulness. I'm not a good advocate for it, but it's not that I'm dissing it. I think it's important, and I think if you like mindful colouring or mindful walking or mindful anything else, go for it.
Oh yeah,
it's about finding what helps you.
Absolutely.
And it's like you said earlier about a toolbox. We all need a toolbox of things we use.
Yeah.
Even the books we read, like I wouldn't read the same on a Friday night when I'm exhausted. I might be reading a thriller or a trashy novel, whereas I might read the more serious stuff on a Sunday night. It's just different things for different times. Back to flexibility.
Yeah, absolutely. There's great research in mindfulness and meditation, but there's also great research in cold showers and jumping into. And I've tried both, and I'm going with the meditation because I absolutely don't like the cold. I don't like being uncomfortable.
Absolutely. Yeah.
So I'm going to go with meditation. It's easier. I don't see bang for buck what I'm getting, but hopefully I'll be this Zen warrior.
There's a book called 10% Happier, which my sister gave me, and it's quite good actually. It's about a very cynical American journalist. He got the short straw, and he was sent to cover religious programs. So he discovered he met these mindfulness gurus, and he just followed them, and then he decided, and it's his kind of reluctant struggle to get into mindfulness, and it's quite good. And at the end of it he said, if we can all make ourselves 10% happier, it's pretty good. And I thought that was good.
That's a good
it's a good one.
Yeah. It's interesting when people talk about mental health, that they talk about what they do, and people say, oh, like I love exercise, but I don't like when people bang on about how great it is for mental health, because I don't think it's the great white hope as they swear. I think it's about finding what you like, what you do, and finding a way of life that works for you. Like exercise, the amount of people that do exercise that still suffer with mental health problems, depression, anxiety. Same people that do yoga, same people that climb mountains. You can be doing it and not get the benefit from it.
And you can also be doing it very obsessively. If you're going to the gym 6 days a week and you're not paying attention to the kids or the wife or even relationships, then it's not good. Or as you said years ago, or not years ago, but months ago at a meeting we had here, you can't outrun a bad diet. Like exercise is good, but diet is important. Back to what you said earlier, it's like there's lots of things in our lives that we need. We need sleep.
To get our ducks in a row.
We do. And exercise is a huge part of it, but it's not all of it.
But exercise in itself, and people don't get this, is a stressor. Like when you do an exercise, you do become more tired. You do need more food, and if you don't eat the food, then that's another stressor. And if you don't sleep properly, that's another stressor. But people go, but it's good for you. But it comes at a price, like anything. Maeve, we're up to 6:30. I don't know if you're missing Neighbours, Home and Away, Corrie, or whatever's on tonight.
5-minute meal.
5-minute meal. Yeah, you're going to go home. Look, thanks so much for your time. I really, really appreciate it.
You're an easy person to talk to.
You just don't say that, because I'm going to get you back on again. I want to get more information out of you. Look, I hope people enjoyed it. I thought it was super impressive. I loved it. Our conversation, it was really revealing. I hope people get what I got out of it. Motivation, inspiration, education. That's what we're going for. If you enjoyed the show, please rate Magic Minds on SoundCloud, iTunes, or you can drop me an email at matt@magicminds.ie. That's all we have for today. Thanks for listening to the show. Go and look after yourself. Do some yoga, do some walking, do some cooking, whatever rocks your boat. Have a great day. Bye-bye.
Well done, you. Hope that's all audible. 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 Hope that's all